Welcome everybody to this interesting session that we are having today with a live case. I am Dr. Ignacio Amat Santos, and I have the honor to have a great panel around me with Joanna, Mani Chopra. We will have also Nicola Corsione, Marek Gigier, Ivan Horvat, Theo Mankilik, Jan Kovac, and some speakers that are in the arena and we will introduce later. Let's see the objectives of the session today. First, we are dealing with a bicuspid case. We are going to challenge the classification and the assessment with a great live analysis in the smart screen. The second objective today is to talk about Octa Pro and how to optimally size this valve in bicuspid patients. And the third objective is to understand the procedure itself, both its positioning, foreshortening, deployment, and also understand the assessment of the hemodynamics, both by echo and invasively. And without further delay, I think it's good if we start by learning a few points of the technology. And I'd like to introduce Peter Vriesendorp. Please, Peter.
Good afternoon. My name is Peter Vriesendorp. I'm an interventional cardiologist at Maastricht University in the Netherlands. The valve used in the live case is an Octa Pro. So just to get everybody up to speed on what this valve is, I'll give a brief overview of its design and the philosophy behind the Octa Pro. As a disclaimer, I'm not involved with its design. I just had the chance to work with it and to observe its performance. And in this session, I'll focus on how the system works and how it's engineered to address some of the challenges we face in TAVI today. Because as we all know, TAVI is no longer just for high-risk patients. We're expanding into younger and lower-risk patients, but also more anatomical complexity increases, such as bicuspid, large annuli. And especially in these challenging cases, it's a patient-tailored approach is essential. And this is not something we only feel, we can see it also backed up by data. If you look at the landmark trial, we know that almost half of the valves implanted in this study were what we call intermediate sizes. So this fits in our toolbox when we're moving forward. Octa Pro was designed specifically with these future needs in mind. It's not a tweak of a previous device, but it's built from scratch, aiming to provide better sizing accuracy, deployment control, and commissural alignment. With the goal was not only to look at procedural outcomes now, but also at our long-term patient outcomes, and then we need a precise, adaptable valve system. I think a key point of the Octa Pro is its predictable deployment. Here you can see the foreshortening, and officially it's 10% on the ventricular side, but in practice it feels like there's almost no foreshortening. And I think that will be demonstrated beautifully during the live case later. This will help with accurate positioning, and I think it's very useful when you try to preserve coronary access or avoid the conduction system. And it adds a bit of confidence during release. The other thing that stands out, and we already appreciate it from the first gen Myval THV series, is the extended size range from 20 to 32 millimeters and a lot of intermediate sizes as well. And it gives us much more flexibility in selecting the right valve for the right patient. And I think it's a practical response to something we need. Here, this is the Navigator Pro. This is how the valve is delivered. Merrill has chosen for a one-size-fits-all, so all valves are loaded onto the same delivery system. And I think the real benefit is in the way the balloon is set up. It has 4 radiopaque markers with a special landing marker, which can be adjusted to the pictal level, and it leads to a 70-30 implantation ratio. And the way the balloon is crimped and the valve is positioned on the valve, make sure it doesn't move during navigating the vessels or passing through the valve. And finally, you need the 14 French sheet. This is the Python sheet. It's 14 French when you introduce it, but obviously it will increase in its size when the valve is passing through. And because it expands and then moves back to its original size, it should be less traumatic for the vessel, in theory. But in all fairness, it's not my favorite sheet, but it does the job, and I think it's a nice combination with the rest of the device. A much more forward-looking design feature of the valve is the Octa Align, in which we aim to have consistent commissural alignment. I think if we think about re-access, re-intervention, lifetime management, you need commissural alignment, and it's, for most of us in our practice with self-expanding valves already, standard practice to aim for this, so we should do it in balloon expandable valves as well. And the way the valve is loaded and maneuvering through the aortic arch helps to achieve this. And I think there's a real promise here, but of course the real test is how it performs in different patients, different anatomies, and I'm looking forward to the real world data on this. And here is a brief example. You can appreciate on the first video how the valve is almost not foreshortening during deployment, and then after the valve deployment in the aortogram, you can see that there is no leakage, there is no need for pacemaker, and even in a larger anatomy, you can appreciate the lack of foreshortening, which I think is one of the key features. All right, so to sum up, I think the Octa Pro THV, it's a thoughtful design. It's aimed at our current and future needs in TAVI, and the combination of reduced foreshortening leading to precise deployment, the extended sizing, and the commissural alignment all point in the right direction. If this really translates into long-term clinical advances, that's something, well, we're starting to see and what we're all going to watch for and hopefully contribute to in the coming years. So thank you very much.
A wonderful picture of the technology picture. Mm-hmm. I think in the panel everybody is very expert, but in the room there might be some people that see this for the first time or they have never had contact with the valve. So in your clinical practice, you have a lot of devices now. Do you have some setting where you really prefer this valve because it offers special features, I don't know, small annuli, calcium, or whatever?
I think and I'm not sure, but for most operators in an already established TAVI center, our first experience was especially in the large annuli, that we're using the 30 to 32 valve devices, and then you start there, and then you start doing more cases, and you start to appreciate the advantages. I mean, another key feature I didn't mention because it was already present in the first gen is that the valve is loaded onto the balloon, so there's no need for extra steps intra-procedural, which makes deployments safe, quick, and easy. Mm-hmm. Right now, it's based on patient anatomy and expectations.
Well, today we'll have a bicuspid case. This is typically a large patient. Do you have some experience in this kind of patients?
Yes, we have, and I think we did it the wrong way because our first Myval we did in Maastricht was a bicuspid 32 millimeter case.
We often start the wrong way. But
yeah, and with tortuous anatomy, and I remember the support team saying, "Really, is this the one you picked as a first case?" But the end result was fine, so I think that also speaks for the valve.
Okay,
a challenging anatomy. So thanks.
Wonderful. Thank you very much for this wonderful presentation again. Let's see the case, Joanna.
Yeah, sure. So exciting. It's a continuation of the previous session where we ended with the bicuspid, so it's a topic of the day. It's an 85-year-old gentleman, so typical TAVI patient, I think, for most of the European countries, who has had for many years moderate to severe aortic stenosis, but was previously asymptomatic, mild iron deficiency, anemia probably from the Haida syndrome. His cardiovascular risk factors included hypertension, dyslipidemia. He was also a former heavy smoker. And since about 2 months, he's been complaining of severe dyspnea and also chest pain, and the symptoms were triggered with actually fairly minimal amounts of exertion, so 100 meters walking. He's further not frail. He is completely living independently without help. These were his laboratory values, so slightly lower hemoglobin, negative troponin, normal renal function. He was using valsartan for hypertension and simvastatin for his cholesterol. And this was his echo, so you can see that this is a fairly vigorous left ventricle, hypertrophied already, somewhat dilated left and right atrium perhaps, so some signs of what we like to call LV damage. It's a classical high gradient aortic stenosis with a Vmax of 4.9 and mean gradient of 50. And he had a little bit of aortic regurgitation as well. This was his coronary angiogram, left dominant system, some irregularities in the lumen, maybe in that proximal circumflex, something that we should keep in mind for the future. But further, nothing that we would have to treat a priori. You can appreciate the severe calcifications in the valve also on the angio. And then, of course, in the workup for TAVI, given his age, he had a CT scan to make sure that the dimensions were appropriate for the TAVI procedure, and then transfemoral TAVI, so his peripheral vasculature was actually not extremely calcified and fairly straight. The annular dimensions were 438, and he had a clear bicuspid aortic valve anatomy, maybe a small raphe, so type 1 valve with fairly calcified valve, calcium score of 3,700. And I think I won't belabor this too much because we'll have a very extensive presentation of CT and how everything was measured, as this is extremely important for bicuspid cases, especially treated with balloon expandable valve. But just to motivate, again, the choice for TAVI, Euro score of 6% and STS score of 3.3%. So the TAVI decision of the heart team was also TAVI. All right.
Thank you very much, Joanna. So we have good clinical information now to take the decisions, and as you said, we need more detailed CT analysis. This is not enough, guys. If you take the decision of which valve to implant and how, with this it was not enough. And now Manik Chopra will show us how to properly analyze a bicuspid case. Manik, the floor is yours.
Thanks. Thanks, Ignacio, and good evening, all. And I would probably start with the CT presentation. So this analysis was done in 35% phase. This is again a systolic phase assessment, clearly seen. And you can see that there is clearly a raphe in between N and R, which is a calcified raphe. It's fused, and it's a bicuspid type 1 NR fusion. There is some degree of calcification in the area of LR commissure, but you can clearly see in 4D that this commissural area completely opens up in systole in the lower part. The same happens in the upper part, in the middle part also, and the same happens in the upper part also. So clearly, it's a type 1 NR fusion. You can see a calcified raphe here, an oval orifice with left leaflet on one side and N and R fused on the other side. And regarding the annulus, it's 23.5, 23.6. It varies from 433 to 438 with a minimum diameter of around 21.9. And LVOT is pretty much similar. Sinuses as such are quite roomy. STJ is roomy. Ascending aorta is not dilated. Now, regarding the calcium complex, of course, it's a severely calcified thing. You can see annulus to LVOT calcium are almost like 4 millimeters into LVOT. A large calcified raphe of around 7.2 millimeters in size, which is also very thick. The leaflets are severely calcified, all the leaflets, and the right-hand image gives you a clear calcium footprint of the valve in question, which will probably translate more to chances of annulus injury, more chances of PVL, more chances of pacemaker. And if you want to measure how do we size it, it's a good idea to measure intercommissural distance, which was 25.3 measured at 4 millimeters above the level of annulus. And clearly it's a flared anatomy, 25.3 on the top and 23.5 annulus. So again, you will go with annular sizing for the valve. Higher up also it's a flared anatomy. Going next, if you use a circle method to understand keeping an inflow and outflow of 24 and placing the circle in center, it looks all good. But the only thing we need to understand is that the circle is going to shift to the left side. this is something which we need to anticipate. The membranous septum is 4.1, which is going to translate more into, chances of heart block. LCA height is all good. I'm going to discuss it later on the smart screen. RCA height is all good. There is enough space in between the valve frame and the aortic root complex, and on the RCA side, the leaflet is also not very long. These are the views, the coplanar view, cusp overlap view, and NR cusp overlap view, or LCC side view, which would be used for crossing the valve, for navigation of catheters, balloon, valve frames, and finally deployment of the valve. And this is, again, clock angle, which is for commissural alignment, maybe related to commissure or to the coronary, but we need to understand he's 84-year-old, and the leaflets are almost ending below the level of valve frame. So, of course, we can try doing that. Aortic arc is all good. Peripheral vessels are all good for 84-year for any transcatheter heart valve, and the aortic arc is also fine if the operators are thinking to do a cerebral protection. Now, the challenges which we have is bicuspid type 1 NR fusion, severely calcified aortic valve complex, and short membranous septum. Most of the consequences I've discussed, but I'll just show you the NR fusion just on the smart screen to make it more clear. Okay, so I tried drawing the areas which are not fused with these dots, which are light blue, and these are the dark blue dots. So clearly, when you transform this to a coplanar view, you can find a fused raphe here. So whatever is going from the outer aspect of the valve is not going to fall in this commissure, and finally it's going to make this step care sort of thing, and then will be pushed towards the outer side. So this bend as such is going to be a challenge for the navigation, for the crossing, for the navigation of the valve, for the balloons and all the other stuff. So this is one challenge which we clearly need to understand with these valves. And the second thing I would say is regarding, if this happens, then probably we would like to use a flexible system which tracks better, or we would like to use a snare to bring it in the inner curve. This is very important when the aorta becomes hugely dilated, because then whatever push you are going is going here, and the orifice is far off. And then coming to the next thing, which is about the coronary obstruction. So you can clearly see, because of this raphe, the valve tends to shift towards the L side. And this is what you would find, your coronary here and then this here. It's very important to measure the coronary leaflet length. So if the leaflet length is, shorter than the coronary height, then it's all good. The leaflet is going to end below the level of coronary. However, if it goes higher up, then we need to understand the space available, calculating the VTC, VTSTJ to understand whether there would be a, impending coronary obstruction. Thankfully, in this case, the leaflet is shorter, and you can see that there's no leaflet seen below the level of lower border of the LCA. So it's all good for this case at least. And of course, the aorta is not very dilated, it's not very horizontal, so it should be fine. And this is one angle which is, again, many people would use, which is called as LCC side view or NR fusion view. So you can see L on one side, and you see N and R which are fused on the other side. You see two commissures which are basically LR and LN on one side, and you see this fused raphe on the other side. This gives you a clear idea of the orifice, where exactly you want to cross. So it's important for two things. One, for the navigation, crossing and navigation, so you know where exactly to cross in and how to navigate your wires, catheters, balloons, and valve frame. And second, again, to understand what would be the shift of the calcium and the raphe when you are inflating the balloon here, or when you are inflating your valve here. So it will tell you whether it is going to shift to this side or no. Practically, you would be able to see the valve leaflet and the coronary height. So it's important to understand the shift of the balloon and THV due to raphe, and also to understand the interaction between the valve leaflet and the coronary heights while you're inflating the balloon, or you're deploying the valve, and probably post-procedural assessment. So this is something different for NR fusion, but let's see how it goes. And I think with this information, I hand it over to Ignacio for further discussion of the heart team.
Thank you. Thank you so much. So, Joanna, do you anticipate any specific risk in this case? Which is your concern? Is more important concern?
Yeah, sure. I think the most important concern is with a balloon expandable platform is rupture. So proper sizing to avoid this, being careful how you do your predilation and eventually post-dilation. Yeah, I mean, in my own clinical practice, that's why I shy away most of the time from balloon expandable devices and bicuspid anatomy and use the Evolute platform. But yeah, you point some things, horizontal aortas, large anatomy above, that makes Evolute also difficult. So having another option that's also safe and has some flex mechanism is also important.
Great. So please use the app if you have any questions. Joanna will be taking care of that, and we will interrupt the discussion just for you. You are the objective of this session. So Marek, we discussed a little bit the risk here. How do you balance in this particular case the risk of annular rupture versus paravalvular leak?
Yeah, thank you very much. Very good questions. In fact, that case very resembled my case from Friday, which was done also with Myval Octa Pro. So I think the key thing is first not to be too much aggressive. If you are too aggressive, there is a risk of the annular rupture. So here, definitely, I will go with balloon pre-dilatation, maybe not very aggressive, so something like 20-22 balloon. And then with the MyValve, I think that there is a good option that we have these intermediate sizes, because you can decide which valve size in that case, and it's very helpful. And then doing that with intermediate size, I think that probably here something like 24.5, maybe with some underfilling, assessment, and then the decision if that valve needs any post-dilatation. So it would be my approach to that case.
Okay. If you have any comments, please.
Again, I mean, clinically 85, no doubt, TAVI is the way forward. Luckily, anatomy, it's not 0, it's number 1. And I very much became in favor of Merrill in this situation, moving from Evolutes. It just expands better. All features are hopefully less risky for any nasty complication you mentioned, because I keep saying it's better to have a mild leak every week than one rupture in a year. So here, luckily, it's flare, anatomy is not too, there's enough space for coronaries. I think Merrill will do a very good job here.
Okay, so Nicola, again, yes. Device choice. What if it were a younger patient? Any changes?
This is the great question for aortic stenosis in bicuspid valve. We know bicuspid is a combination of several anatomical challenges, like from the annulus too large for elliptical annulus, the presence of the raphe, the amount and distribution of the calcium on the annulus or below the annulus, then the height of the maximum constriction of the valve. This is type 1. And then the aorta. Aortopathy is a combination of horizontal aorta and the dilatation of ascending aorta. The right choice is not easy, but we need necessarily a careful analysis of the CT scan for the side. In this case, it's a heavy calcified type 1 bicuspid, but there is a flare anatomy, enough height of coronary ostium, and we can maybe use a balloon expandable valve. I'm so excited to see the case.
Mm-hmm. Someone in the audience is asking about, I think, the risk of the embolization of different valves in the bicuspid anatomy, especially balloon expandable, and whether you need to have a snare ready.
Okay, maybe Manik, you want to comment on risk of embolization?
So for sure, in this bicuspid anatomy, where you have so much of calcium for anchoring, and we know that in bicuspids, the valve can also anchor probably above the level of annulus, the risk of embolization for balloon expandable valves, I would think that if a proper pre-dilatation is done, is very less. For self-expanding valve, again, you need to be sure that you have aggressively pre-dilated it well, so that the valve expands reasonably okay and the nose cone doesn't get stuck. It's a good idea to check in LAO and RAO view before you pull it out, because sometimes it gets inverted and you have an embolization with that. That is what I would probably say.
Yeah. If I may, I would just comment, with self-expanding, you have a pop-up with difficult anatomy
Yes.
in the best of days. So advantage of balloon expandable, which is generic, especially this one, if you prepare case well, you are like sniper. Good pacing, pressure drop, you are in the place. I don't think can embolize.
So systematic pacing.
Doing
before
all those
release?
small things before you hit it, and that's what it is.
Okay.
And in comparison to another balloon expandable valve platform, the new transcatheter valve Octa Pro has some advantages, like the underlined intermediate sizes, like in this case. And also the foreshortening is very, very important when you implant the balloon expandable valve in bicuspid anatomy. So very low low shortening, I think will make a great advantage.
But sometimes positioning can be a little bit more challenging, right, in bicuspid, because the annular plane that we usually detect is a little bit higher if coaptation is higher. Do you change something in your positioning during valve implantation in bicuspid patients according to the analysis, or you just use the annulus?
It's very important to look at the supraannular measurements like the anatomy tapered or flared. If tapered, maybe it will be better to choose a smaller size. But in this anatomy, flared anatomy, we can put the valve according to the annulus measurements.
Yeah, I would agree. If it's tapered, you enter to go smaller and higher. If it's flared or just column, then you take annulus.
So we have a warning from the audience that 24.5 with 8% oversized is perhaps too aggressive. And we also have a question, is there an app on sizing strategy?
Of course, there is a non-sizing strategy in balloon expandable valves, like a balloon sizing method. By contrast, inflation. When you inflate the balloon, you give the contrast. If it's, for example, a smaller balloon than you may expect it, you can select a smaller size of balloon expandable valve. On-site measurement is directly related with the balloon valvuloplasty.
So there is one app that is called TAVI sizing that can be used to decide the size of the balloon. And then usually, this is a gross view, every extra or minus cc is around 0.3 millimeters change in the diameter. This, of course, will not be linear. If we go 6 cc, this is not linear, but it's also orientative. I wanted to ask Ivan, because he has huge experience in bicuspid, how do you see this case? How would you approach it here?
First of all, just one remark. If somebody is not as expert as you at the table, maybe the last minute to change the mind or change the size, and there will be a pre-dilatation, there will be the balloon inflated, and that time an injection and take a picture, that's a very good idea to overthink whether it will be a good size. That's just one.
Alan Cribier used to do all cases like that, and it's that ultimate reassurance. If there's smaller balloon and is no leak, you are reasonably confident that whatever you've chosen, you can be conservative.
I was going to disagree, but then you say Alan Cribier did that, so I cannot disagree. But one thing is important. If you do a large balloon inflation and the valve is not ready, some patients can have severe regurgitation, and we have to be careful.
Always have a valve ready. I've done proctoring our valve 15 years. No, you have to have once a year happens, and you don't want that.
So you use
valve needs to be ready before
you
you go.
used to overfill or underfill, not to select the size of the valve, right? That's it.
Yeah.
Sorry.
This is the main rule of the cath lab.
Yeah.
So, by the way, also in the chart provided by the company, you also can adjust the amount of oversizing based on calcifications. And so, if you are a very little calcified, then you can go up to above 10% oversizing. But if you have a lot of calcium, then maybe 5% is better. So, that's all.
So, thinking
available.
in the procedure now, we will briefly mention how they are planning to do it. Nicola, I'd like to know what you do for pacing in these patients. This is a short septum, membranous septum, highly calcified. Do you pace over the wire, use a pacemaker lead transitory?
We use always a pacemaker with the balloon on tip. And in this case, is very, very important to get a stable high rate in the pacemaker, maybe in stable position to get the stable position on the valve during the release. It's very, very important because there is a lot of calcium below the right coronary cusp. This is maybe a problem, and it's very important to get a precise position of the implant.
Okay, wonderful discussion. If there are no more questions from the audience by now, I think we can move to the operator's strategy. This is what they are planning to do, that I will briefly summarize. So the idea is to have dual vascular access. The primary will be femoral, the secondary access will be radial. The working projections, I think they have been nicely shown, and they will show it for us. They have estimated both 3-cusp and 2-cusp view, maybe to verify the commissural alignment at the end. Then for predilation, the idea is to go with a 22 millimeter balloon, non-compliant balloon, and they are planning to implant an Octa Pro 24.5, probably with some degree of underfilling, but I think it's better if the operators explain to us their rationale for this selection. And of course, they will have echo and invasive hemodynamic assessment of the case that we will show. I see they are already connected. Let me introduce the interventional team. First of all the team that is around the operators that are crucial for the success, the nurses Tania, Elena, and Alba, the anesthesiologist Charlie, the medical coordinator Gabi Tirado Conte, and of course the orchestra director who is in the shadows, Marco Lombardi, who is here taking care of everything. And we can already see you, the operators, Pilar Jimenez, Luis Nombela. Hello from EuroPCR. How are you in Hospital Clínico San Carlos?
Hello, good evening, and welcome to our live case in our hospital. We agree with all comments, some of the comments that you have made, and we are ready to show you what we have done so far. So, as you said, we have parameter the right femoral. We already have the Python sheath, which is a 14 French sheath for all valve sizes. And then we have the radial with the bicuspid in place, because a very calcified valve and short membranous septum, we have a pacemaker lead at the right ventricle. And I would like to show you the hemodynamics pre. Can we see them? This is we have a mean gradient of almost is 45 millimeters of mercury, and the echo, the measurement from echo, I don't know if you can show the echo, it's almost 40. So we are ready to predilate. This is a non-compliant balloon. This is a 22. It's 1 millimeter bigger than the minor diameter. We want a very good predilatation in this complex bicuspid scenario, because we want to open as much as possible and to apply less force during blank implantation. So we're ready. Pacemaker on. Marcapasos on.
So as Pilar said, we are predilating this valve with a true dilatation balloon 22. Okay, marcapasos off. And as you have seen, we show this waist, and hopefully we open this valve between, as you know, this valve has a raphe between the right and the non-coronary cusp, and also the left is heavily calcified, so it's quite challenged bicuspid anatomy. You were discussing during the strategy.
Yeah,
we were discussing that probably the size of the valve, the 24.5, will be quite oversized for this anatomy.
Can you explain?
So we have decided to.
Can you explain what you are doing now?
We can show you.
Now we are delayed the sheath with a 18 French
dilator. Yeah, this is the 18. You know that the sheath is 14 French, but before inserting the valve, we have to dilate the sheath with an 18 French dilator, to make the sheath bigger.
In fact, in my practice, we are doing it a little bit differently. By immediately after inserting the Python sheet, we are not removing the dilator at once, waiting 2-3 minutes before going with the balloon. So I can see that you are doing that differently. And if you can comment, which is your preferred
important point?
Yeah, which is your preferred wire for the Myval Octa-core? Is it Safari inside or it's Confida? What kind of wire is it?
No, it's Safari. It's an extra small Safari.
Extra small.
For dilating the
so now
sheet,
we are
sheet, for the smaller valves, for example, in our institute we use, for example, for 24 we don't use the 18 French sheet, but instead of using that we put some propofol inside the sheet, and it helps very, very.
They are about to advance the prosthesis. I think it's nice if we have a look at how it looks. Can you explain a little bit, Pilar, please?
Can you?
Yeah, this is the valve is already crimped.
Can you make a zoom?
So you can see the valve inside. You can check it.
Yeah, great.
And the only thing you have to do is to advance the valve and then to position it. You don't have to follow any step further.
Okay.
So now we are advancing. So let's check this.
Okay. Looks
and
like.
Before you, I don't know if you see the end of the sheath, the distal part, but before the valve came out, we have to check. Stop, Pilar. And we have to check that the valve is well aligned with the balloon. So at this point, I think we can. The valve is correctly aligned with the balloon, so we can advance and get out into the patient body.
So there might be some risk of sliding if the femorals are too tight. This is what you mean, right?
Yes, because that's why we have already dilated this part, and because the valve it's already crimped in the balloon, we don't have to do the balloon alignment. So one moment, please, Pilar. So we are going to go in a more.
So another thing is another feature that I like that if you have any problem, you can retrieve the valve through the sheath.
Mm-hmm.
Okay.
Ignacio, do you like the wire position in left?
So the curve of the Safari is.
You see that there is 4 markers in the balloon. The 2 at the edge of the balloon, 1 in the middle. But the most important one is the position marker, which is between the mid and the distal. You see? And we have to position this marker at the bottom of the annular plane. So you can get implantation 90-20.
How is the crossing with Octa Pro? Because they mentioned that they have increased a little bit rigidity of the distal part. Mm-hmm. Did you feel it for a bicuspid case, or was as usual? The crossing ability.
For me, it was as usual.
Similar, okay.
It was similar. No, we didn't have to push a lot. Of course, we have already dilated this valve. So now I think we can discuss. We have the 3-cast view, the cast overlap, and also a projection that we are going to isolate only the left cast. So now at this moment we are in the 3-cast view. We can do an angio, but of course, as you can see, there are some parallax in the valve. So probably we have to correct, and see in the cast overlap we can correct this parallax. But let's do an angio here.
Only angio.
So, as you know, in this valve doesn't foreshorten in the ventricular side, or at least very minimum. So we usually place the pigtail at the bottom of the black point in the middle of the valve, and then see if because the foreshortening of the ventricular side is very minimum. We can have a very high implantation at this level. So now Pilar has moved the X-ray, and we have removed the parallax of the valve here. As you can see, here there is no parallax, and then probably we are going to do another injection in this.
I give a caudal.
I think it's a little bit high because we have some movement of the.
There is some movement. Maybe some pacing could help during the angio to get them.
No, the gas overlap doesn't help. So
perhaps I think. Can you pace at 100?
But we are going to do an angio.
Venga,
Okay,
a 100.
The panel is
I'm
commenting.
going to pace 100. Let's see if the movement is less.
Okay, they are doing an angio with
I
pacing.
think the position is okay, yeah?
Ivan commented also that it's important to push properly the wire. I think it's correct, but this pushing of the wire is important. But if the LB has a correct function, then it also moves the wire, and maybe this is what might be happening. It's relatively stable, little bit of movement, but.
So we like this position. So if you agree, we are going to implant.
Okay, go for it.
We have to push a little bit. We have to have the tension of the wire.
And that's what.
And then we are doing an angio.
They did it.
The rapid pacing.
During the injection.
Okay.
Can we take a video?
Okay.
Okay. So pacemaker on.
So they did a rapid pacing and injection just to check what was going to be the
injection.
Position now.
Okay.
Good.
Okay. Now for shortening, looks nice.
Looks nice.
Perfect. So there's a question whether you prefer to place the valve a little bit higher in the bicuspid.
Let's see the recovery. Please, Joanna, ask the question.
So do you place it a little bit higher in the bicuspid case, sort of on 10-90%, or just as usual?
Well, of course, you in some cases of the bicuspid, you can implant higher because you know that at the level of the raphe, you can have also some anchoring. But in this case, the intercommissural distance was bigger than the annulus, so we usually implant in these cases 90-10, which now I think is more or less the case. 90-10 is highly or is still a high position, but of course if you aim for a 100-0, also is usually is fine. We didn't have problems for anchoring, and probably now we have to assess the geometry of the valve, the expansion of the valve, and of course if there is some paravalvular leak or gradient,
so
just in case that we need to post-dilate or not.
The other question from the audience was that you mentioned that you are using a little bit of an underfilling technique where you can play additionally with the volume that goes into the balloon. But somebody raises a point that if you use a bigger valve and underfill, then you run into risk of pinwheeling. So can you comment on that?
So we calculate the oversize with the nominal volume. The oversize was 9%. We thought this was too much. So we know that each cc less is 0.3 millimeters less in diameter. So we calculate 2 millimeters less. So the overexpansion is 4%, which is better for us. If we choose 23, the expansion is minus 2%. We thought this we need a little more. That's why we choose to implant 2 cc's less.
And with 2 cc's less in this valve, the size of the valve will be around 24. So I think that this is not a risk for pinwheeling of the leaflets, because it's not down. I mean, it's not a big downsize in the nominal size of the valve.
We are seeing some echo images, and we see.
Yeah, what do you think?
some regurgitation. What do you do with the wire usually? So you do an angio with the wire in place, you remove completely, you put the pigtail in. How do you manage this?
So you can see, yeah, you can see there is no perivalvular leak. There is an intravalvular regurgitation, and the gradient is bright. So there is a velocity of 2 meters per second. So 8 millimeters of mean gradient. So I cannot see any perivalvular leak. Just the
Okay.
and there's no pericardial effusion. So I think it's.
I think, Ignacio, we have answered your question. When we check with the echo, and if there is no paravalvular leak, I think we are ready to remove the balloon, and because we think that we are not going to post-dilate, and then we usually insert a pigtail through the safari wire, and then remove the safari. That sometimes, as you know, is causing some central leak in the valve. So we are going to check it now, and then we can also assess the invasive gradients
Forward.
with the pigtail inside in the left ventricle.
And I have one more request. I think
If we have to post-dilate, we think we are going to add the 2 cc's that we take off previously with the same balloon.
Okay, let's see the hemodynamics. And we have one more request. At some point, it would be nice to see the cusp overlap to understand what happened with the commissures in this patient, because by fluoro we can see them quite nicely. Maybe you can show later.
Yeah, we are going to show you both angiographics. In fact, well, let's check the hemodynamics, and then we can talk about the projections in the fluoro. I don't know if you see maybe we can do it bigger, the hemodynamics.
Un poquito de suero.
Are you guys doing it systematically,
Yes,
the hemodynamic assessment invasively?
Yes.
Sure.
Okay, pero
Especially aortic regurgitation index is very, very important for after implantation. So we can assess by the hemodynamic analysis.
I have to confess that for a while we stopped measuring the invasive hemodynamics, but now we are back, especially so many small annuli, the challenge between supraannular, intraannular. So I think it makes sense to measure systematically.
You are in a lab, you spend all money, so it takes very little to pigtail. Yeah.
Looks good, Luis, Pilar.
yeah, we are going to perform a angiogram, aortogram. So
I think we can. Well, do you prefer to leave the pigtail or?
no, let's leave it.
Okay.
So the position is good.
Yeah, we would say that it's 1090, and we are now you were commenting, Ignacio, about the projections. We are now in a LAO cranial view, or more LAO, that we have isolated the left main, and this was the projection that you see the valve less
Parallax, with less parallax.
With less parallax and less expanded, because this was the projection, because the raphe was between the right and the non, and we have calculated this projection with the trimension, and is less expanded. And also, you have seen in the injection that we have 2 posts of the commissures between the left main. So the commissure alignment was fine, because you see the 2 posts of the commissures of the valve, and in between these commissures is the left main. We have isolated, and then we are going to turn into the cast overlap, which is usually caudal and
The post that you have to see is the post that has 3 holes.
Yes, and here in this, maybe you can do a cine, Pilar, without injection. So here you can see that there are 2 posts in the left part of the screen, and 1 post in the right part of the screen. So again, we can confirm that the commissural alignment is well calculated and well done.
It's great. So you have great hemodynamics, no paravalvular leak, good expansion, commissural alignment. What about the conduction system? What is the assessment now?
Can you show the?
Yeah, there is no. We have a narrow QRS, and there is no any conduction disturbance right now. So hopefully the patient, or probably likely the patient, will not have any conduction disturbance during the hospitalization.
Before you answer, I'd like to know what does the panel with the pacemaker in this situation? Do you remove the pacemaker, the venous access? Oh.
Yes.
Yes.
Yeah.
If there is no.
Yeah, definitely. If there is narrow QRS complexes, we remove it immediately after the case, at the end of the case.
And the central catheter also, I mean.
Leaving a pacemaker is only a risk of, I think, perforation when they go to the CCU and they start moving, and you want the patient mobile as soon as possible.
You saw how nicely, while we talk, Luis did the kissing pigtail technique to bring the pigtail from the
Oh yeah, I'm gonna show you.
Story it, Luis.
Yes.
Don't do trick thing. Don't do this.
I'm gonna show you. So we want to to place the pigtail from the radial to the descending aorta. So we use the pigtail from the femoral artery to help us to guide the other pigtail to go in the descending aorta. This is called kissing pigtail.
That's great.
Great.
Wonderful trick.
Regarding the pacemaker, I think we are.
So you heard what the people in the panel said they would do with the pacemaker. Do you do the same, or your protocol differs?
No, because the patient didn't have any conduction disturbance during the case, so we wanted to implant the pacemaker because, as you were mentioned before, we want an stable, rapid pacing, especially in bicuspid cases that sometimes you know that we have some movement of the valve. So we want a very stable, rapid pacing. But now, because we have sinus rhythm, narrow QRS, so I think we can remove it and send the patient to the ward.
How long is the patient? In my place, this patient go home tomorrow. Was night in Spain. When is patient? What happens next? When we are sending patient home? Any parameters he should delay discharge?
We usually keep the patients 48 hours. So we participate in some protocols to discharge the patient after 48 hours. But of course, if the patient, there are also some publications that if the patient has no vascular complications, that we are going to check after that, and no alteration of the conduction disturbance. So you can also discharge the patient after 1 day.
I would like to add that in the Spanish registry, the median time for discharge is 3 days.
Okay. So we still have a few minutes, guys. If you want to proceed with the vascular hemostasis, I think people would love to see how you handle that and how it works.
Yeah, and if you can tell us how that patient was, it is 1 proglide, 2 proglides, what was at the beginning? Or it will be MANTA, what was the approach? Because you haven't mentioned that.
In this case, we use 2 proglide. So sometimes we use 1 proglide and 1 collagen device, but this case we have used 2 proglide.
Okay, let's see what the panel is doing while they deal with the femorals. What in this patient, we saw the CT, so you know perfectly the patient and you can plan the procedure as if you were the operator. So let's start from Manik. What would be your approach for the femoral access?
I would do it pretty much similar. 1 proglide, 1 angioceal. That's my standard practice, but I'll keep the bailout stuff ready with me.
Okay, so Nicola?
My clinical practice is always with 2 proglides, or 1 proglide and 1 angioceal.
Okay, Jan?
1 proglide, having 2nd proglide available if needed, angioceal if needed.
Okay.
1 prostyle and 1 angioceal, 8 French, and indeed we usually have secondary access not via radial but via the other femoral, just to have a shorter route to be able to place a covered stent if need be. But with this technique of combination of suture device and an angioshield, it's rare that we need to use that.
Now we have some balloons that are long and can be brought from the radial, which is the Oceanus balloon, and some stents that also can be brought from radial, and it's very interesting when this approach is used. Sorry, Jan.
We didn't see the puncture. Was it ultrasound, angio-guided, just by palpation? Or how did you do puncture, large bore on valve sites?
They are now focused on the closure. But I know how they work.
The puncture is ultrasound guided.
Ultrasound guided, yeah.
I don't know if you can see here, maybe with the...
We can see your hands perfectly.
So important to put your dilator back in so that, because obviously the sheet has been split.
And then also we leave the wire, we check with the wire if there is some bleeding, and if we don't have bleeding, like in this case, so we will remove the wire in a second.
Before or after angio? When do you remove the wire?
We usually remove it before the angio. So right now that there is no bleeding, we remove it, and then we will do an angio at the end. We have already closed the first proglide, and then we will do the second one.
Any of you guys keep a wire as a crossover just in case?
Actually, I always prefer when, for example, calcification present, I always prefer to crossover technique with a safety wire. One case, if complication occurs, it's the case.
Okay. Looks promising.
So it's okay.
It's fine. And then let's do... We are going to put the pigtail down to do an angio. And then also...
Normally we do an angio in all patients. What do you do normally? You check in every patient the femoral artery, or?
So from this side?
You do it with echo.
Systematic angio.
Yes, systematic.
Systematic?
Yeah, systematic angio in all the cases.
Over there? Yeah. Any of you is evaluating by echo the femoral at the end?
No.
So this is a strategy that some teams are using now. It's more difficult to see the bleeding, but it's good to see if there is any residual stenosis, and can be enough in some patients, especially if it's difficult to bring the catheter.
All the procedure with the crossover, and the endoclamping during the angiosheal closure. Then we open the balloon, check the vessel. If there is some residual stenosis, we are already inside, and we can inflate the balloon.
So you do a dry hemostasis, with balloon inflated.
Yes.
Okay, this is something sometimes we do in the subclavian, but no longer in the femoral. But it's a good strategy to avoid closure of the vessel with the proglide. Okay, let's see.
Okay, so we will do the angio.
This was a fairly high bifurcation on the right side, actually.
Yeah. Actually, it was.
Yeah, I don't. Yeah, it was a high, and we puncture a little bit higher than this bifurcation, but it seems that there is no stenosis, no bleeding. So I think we are done. We have already removed also the pacemaker.
So guys, you did a wonderful job. That was a fantastic case with great outcomes. Congratulations. Okay, we have some more comments to discuss here on the table. Just to do some, during the case, there were some comments that I think is now the right time to bring them back. One of them was, at some point, the wire was not facing down, was facing up. Yeah. You mentioned that. What was your concern? What should we do?
Actually, it's very, very important because the part that change in the pre-shaped guide wires must be avoided from the left ventricle apex. Then in rare cases, rupture can develop when you insert the valve.
It's also with coaxiality in some difficult anatomies, because if it's natural curve, it's better, A, and B, if you're using pacing of the wire, it could be disastrous if anything moves, if you don't have a temporary wire. So general, it'd be good to have a pigtail-like shape in all cases whenever you can.
So this happens in bicuspid. Manik mentioned this.
And I think that in some platforms, it's especially important that the wire should be positioned opposite like it was here. But with Myval, I'm not sure if it's so important. With Evolut, it's probably not so important. With accurate platform, is crucial.
Exactly. Good point. Good point. So Manik, during the analysis, we saw the 3-cast view, we saw the 2-cast view, but they did also an isolation of the left sinus. Can you mention something about that? People is doing this. Is it worth?
Sure. So I can.
Let's see the smart screen.
Okay, so I would probably.
So Manik took some pictures from the.
Yeah. Do you want to see that first, or?
Now we can see it.
Yeah. Okay. So then this was some key highlights of the case, and you can see that this is how the valve was being placed. The initial positioning of the valve, and you can see the top portion, you can see the bottom, and you can see the marker. It's aligned to the non-coronary cusp, and really the valve is being placed very high, and that is how you would do. And we also know that in bicuspids, the leaflets are quite tall, so you would like to pin the leaflets. You don't want to be low in any way, and this is how it was inflated. You can see there's hardly any foreshortening seen, and you can keep your eyes at the lower border of the non-coronary as well as at the top. Just as reference marker, I have put these lines, and you can see there's hardly any foreshortening. So, and the valve remained very stable. So, 2 key points: one, to place it as high as possible with the marker, and second, go slow for inflation because it's hardly foreshortens, and you can see there's hardly any foreshortening. So, it's almost like a very neat and simple procedure. Yeah, and regarding the isolation part, there was a Can you take this video off, please? Yeah, okay. So this is again the view in which you would probably isolate the left coronary sinus, and this is your left coronary artery. This is your leaflet. This is where the top of the calcium is ending, and this is where the valve is going to be expanded very soon. So this would in fact tell you the relationship of the top of the leaflet with the top of the coronary, the bottom of the LCA, so that you understand that is there any risk of coronary obstruction. Also, it tells you as to how this raphe has behaved. Has it pushed the valve to the opposite side or no? So the LCC side view would guide you regarding the shift of the valve to the opposite side, and also to understand the coronary part.
One more thing. We discussed a bit about the commissures. I'm not sure if everybody saw it during the live case. Yep. Can we see the valve? How we see them? Can we see in the smart screen the processes?
So, of course, I was not able to capture that view if they have taken a RA or caudal view. I'm not sure, but for sure in this, it's not a very high resolution image, but probably it's here, one commissure which I could see, one commissure here, and I don't see the third one. So it's almost similar to the previous generation Myval. Yeah.
Okay, great, thank you. Any comments from the panel regarding the case? Okay, if there are not any... Yeah,
just a question. Did you consider, for everyone for the panel, consider in this case a cerebral protection?
Good question, because evidence-based, no.
Well,
in this case?
Evidence-based, no. For me,
no.
You cannot, for a negative trial, you cannot do the subsets to say that it's important in one subset. I think the only people that I would consider it in is when you do leaflet modification, because that's extremely high risk of stroke.
Or valve-in-valve, maybe, without leaflet modification. Yeah, some discussion there.
We just keep dreaming on.
Yeah.
And 85 years old patients, durability, maybe we can make a little comment.
Yeah, true.
Actually, there is no limited data. There is limited data about the long-term durability of TAVI valves in patients with octogenarians. But rather than durability, we had to speak maybe early bioprosthetic valve failure in these patients. So, for example, in this patient had a lot of risk factors like bicuspid aorta, diabetes mellitus, hypertension, and then actually a relatively small annulus. So it is better to implant a good size balloon in this balloon expandable valve in this patient.
Good point. So now I have the honor to introduce Professor Andreas Baumbach to present the one-year outcomes from the landmark trial. Thank you, Andreas.
Thank you very much, Ignacio, Joanna, ladies and gentlemen. This is hot off the press. This was presented this morning, and then with a couple of added-on findings throughout the day. So I hope you find it interesting. These are the one-year outcomes of the landmark trial. That's me. So we know the whole series of Myval is relatively new. We have demonstrated non-inferiority compared to the contemporary standards, SAPIEN and Evolute, at 30 days, and that was published in The Lancet, presented exactly a year ago here at PCR. This is now the one-year clinical trial. This is the landmark trial for those of you who haven't seen it, or just to remind us, 768 patients, 384 in each arm, Myval THV series on the one hand, and contemporary THV, and that was made up of equal parts of SAPIEN and Evolute. That's the trial, randomized, controlled, and we've done the 30 days, we looked at 6 months, but now we're at the 1 year stage, and that was the pre-specified efficacy endpoint. We will see this out through 10 years, but now we're here, and that is very important. Now, this was the first study, and we had a big presentation of Professor Onuma this morning. This is the first trial that really uses VARC-3, and if you care to read the document, it's an amazing amount of tables and things you have to look for. This is the event committee that should be mentioned. They did a tremendous job in adjudicating all these things according to VARC-3. Basically, we're looking at all-cause mortality, all-stroke hospitalization, but then also at the type of bioprosthetic valve dysfunction, hemodynamic valve deterioration in 3 stages, and clinical valve failure. I won't bore you with the sample size calculation. It came up at 768, so that was all good. This is more important. Looking back, these trials become at some stage obsolete because there's always a new valve, a new valve, a new valve. For this trial, we had the Myval original and then the Octa in the Myval part. We had the SAPIEN and the SAPIEN 3 Ultra, not the Resilia yet, in the SAPIEN arm, and Evolute R Pro FX and Pro Plus in the Evolute THV series. And we'll call this series from now on, but now you know which valves were involved. It's a relatively old, low-risk population, or standard all-comers population, median STS score 3%. We had good going aortic stenosis, 0.7 square centimeter in both arms, very well randomized. The mean annulus area of 471 here, again, beautifully randomized. And bicuspids, we've just seen a beautiful case at 6 and 7.5%. So these were really all comers. Essential results at 1 year, all summarized in this. Clinically, mortality 7.2 and 7.1%, no difference. Stroke 5.7 and 3.4%. There was no statistically relevant difference. We don't quite know why this happens here at the end, and we'll have to see what happens in the long run. But there's no difference. That's important. Rehospitalization, 4.3 versus 5.4%. That's 16 and 20 patients, and again, no difference. And if you take all three together for the combined endpoint, then we're at 13 and 13.1 with really no difference here. Echocardiogram, we've seen interesting data at 30 days, and that is continued. The results are stable. This is the Myval series on the top, and then on the bottom, contemporary and effective orifice area, 2.11, 2.1, no difference, of course, and the gradients, again, below 10, low gradients, after 1 year. So we have this, as a scatter diagram here, again, orifice area and mean aortic valve gradients. Aortic regurgitation, bit of a discussion about that, but if you look at the occurrence of moderate or severe aortic regurgitation, there was no real difference between the two arms, 1.6 in the Myval series, and 3.3% in the contemporary series. Now, hospitalizations, we had that as one endpoint. We can break that down. This was in the deep dive. We did that. Out of these rehospitalizations, we had 9 in each arm for new complications. We had heart failure-related hospitalizations, exacerbation or deterioration of previous in-hospital complications, 1 each, and 2 bioprosthetic valve dysfunctions. And these are, again, the total numbers here. If you look at the bioprosthetic valve dysfunction, there is structural heart valve deterioration, like flail leaflets or something really substantially wrong with the valve, 1 in the contemporary series, nothing in the Myval. We had 36 and 45 non-structural valve dysfunction, which mainly is regurgitation or patient mismatch. Thrombosis 4 and 5, and endocarditis 4 and 1. And again, these are small numbers and definitely no difference in terms of statistical significance. The hemodynamic changes are now, according to VARC, stage 1 without hemodynamic deterioration, stage 2 with moderate, and there's complex echo parameters here, and stage 3 severe hemodynamic deterioration. How did we fare? We had stage 1, 7 in the Myval and 4 in the contemporary series, that's below 2%. Moderate, 2 and 2, and severe and none, in no cases there. Then clinical, which is really bad, bioprosthetic valve failure, stage 1, 1 and 3, stage 2, which is usually aortic valve reintervention, more in the non-Myval group, and valve-related death, 2 each. And I'm told it makes sense that the percentages here are different. That has to do with the time point at which things occurred. And finally, we took VARC3 really by the letter and included a quality of life endpoint, the SF12, and a reduction of more than or equal 2.5 points was deemed binomially was deemed significant and added to the endpoint, and that happened in 29 and 38 patients in the Myval and contemporary THV series for the combined endpoint up here. But overall, the message is there is absolutely no difference. So for the treatment of patients with symptomatic severe native aortic stenosis, the Myval THV series at 1 year was non-inferior to the contemporary THVs made up of SAPIEN and Evolute with respect to clinically efficacy endpoint with a 13.1% versus 13%. It's the first head-to-head trial using VARC3. And the hemodynamic results with a 93% echo assessment at 1 year provide robust conclusions on the stable hemodynamic performance of the two arms over a year. So Myval demonstrates a comparable survival to contemporary THV series, underscoring the overall safety. And with that, I thank you for your attention.
So we are running a bit short of time. We are moving on to the next presentation, and we might have short time for discussion by the end. The next presentation will be the Compare-TAVI trial, a 3-year update, and will be presented by Dr. Christian Jules Derkelsen. Welcome.
Thank you. So I'm going to present the same presentation as this morning's late-breaking clinical trial, 3-year results of the Compare-TAVI 1 study. These are my conflict of interest and disclosures. Compare-TAVI 1 randomized 1,031 patients 1-to-1 between SAPIEN 3, SAPIEN 3 Ultra, and Myval versus or Myval Octapro, published in American Heart Journal and Lancet just last month. It proved that at 1 year, Myval was non-inferior to SAPIEN transcatheter heart valves regarding the composite of death, stroke, moderate, severe aortic regurgitation, and moderate or severe hemodynamic valve deterioration according to WARC 3. And you can only evaluate this after 1 year, so it made sense to wait until after 1 year to present the results. But we still need long-term durability data, and if you look at the enrollment in Compare-TAVI 1, you can appreciate that we randomized the first patient in June 2020. This patient is now 5 years out, and the last patient was enrolled in November 23 because during the enrollment we had to pause inclusion for 12 months due to patent-related disputes between the companies. But in the early phase, in first part of the study, we randomized between Myval and SAPIEN, and when we initiated the study, Myval was replaced by Octa Pro. So actually in the Compare-TAVI we have 2 studies now. And it happens that the first part of the study, patients crossed 3-year follow-up in August 24. So we actually have complete 3-year data for this group of patients now. So the aim of this presentation was to evaluate 3-year composite endpoint for the first part of the Compare-TAVI 1 trial. So you see here 379 patients randomized. It's around 1/3 of the Compare-TAVI cohort, 192 to SAPIEN 3 and 187 to Myval. And actually it happens that 192 is the same number of patients as randomized in the landmark study. There were 4 crossovers, so in the per protocol you have also 192 and 183, and as treated you have 196 and 183. The baseline characteristics, the same, 81, 82-year-old patients, mostly male, the majority New York Heart Association class 2 and 3, and the majority have an STS score below 4. Here you see the valve morphology, so around 7% bicuspid and around 4% valve-in-valve. And here you see the results. So at 3 years, there were absolutely no difference in mortality. There's a mortality of around 6% for each year. So at 3 years, you reach 18% in both groups. This is an all-comer trial, so that this reflects daily practice. If you see at the stroke, at 3 years, there's also no difference. And here you then see the primary endpoint. So you can see the composite endpoint was 28% in both groups, no difference. And as said, no difference in death or stroke. There were a little more moderate to severe aortic regurgitation in the Myval group, and you could then speculate, is that because it becomes worse over time, but it's not the case. Actually, these were the ones who also had moderate to severe at 1 year. So in the total Compare-TAVI cohort, it's only 3%, which is explained by less aortic regurgitation in the octa-core group. And here you see the pacemaker. So when only comparing Myval and Sapien, it's like around 15% and 20% at 3 year. So we conclude that at 3 year, the two valves are comparable regarding death, stroke, aortic regurgitation, and hemodynamic valve deterioration. And I guess these are the essentials to remember. We have to remember that it was an all-comer trial, Compare-TAVI 1, randomizing nearly 80% of all patients treated. I still think it's important to follow durability, and we will of course also present 5 and 10-year data when we reach 5 and 10-year follow-up, which is very soon for the first cohort. Thank you.
Congratulations for this investigator-initiated study, which gives a huge validity to our clinical practice. And we need to move on to the next presentation due to time restraints. So now we are going to see what happens in real world. These were very pragmatic trials, but we also need to understand if they translate properly in our clinical practice. And for that, we have Hale Smallman that will present the experience with Octa Pro, the new generation, in his clinical practice. Thank you.
Perfect. Thank you very much, dear Chairman, ladies and gentlemen. So we have to switch gears a little bit. We were talking about the Myval, the latest generation is the Octa Pro, and I was asked to give some real-world experience about this valve. And when I prepare a talk, I always look first into the scientific background, and exactly that was done in this case as well. And I put Octa Pro in PubMed, and you can see there are 3 publications. The first one is mushroom poisoning in Thailand between 2003 and 2017, probably not the topic I was supposed to speak about. Therefore, we have to conclude that there is not real data available today. So everything I share in the next couple of minutes is more or less personal experience, and perhaps we have a minute left afterwards to discuss what I'm telling. So I have a case, and I would like to use this case to bring up some positive points, some perhaps not so positive points. And let's start with this 84-year-old male patient, low flow, low gradient aortic stenosis, effective orifice area 0.7 with a moderate calcification. And you can clearly see that this is a rather large anatomy. The perimeter-derived annulus was calculated as 32.1 perimeter, more than 100 millimeters. So this is clearly a large anatomy, which would be difficult to treat with other devices. And there comes the first point, which is really important to mention. So there is a really large variety of Octa Pro sizes available, starting from 20 to 33, 9 different sizes, which personally I find very helpful to have these intermediate sizes as well as these large sizes. And in my personal practice, the large size is the valve which I use most. So the same was done in this case. Coming back to the case here, you see this moderate calcification, and you can of course appreciate in the lower right panel that this is really large in this case. Coming to the valve implantation, you can see here how we placed the device, and the marker really makes it easy to position the valve initially. With this marker deep down in the cusp, you're always on the right side, and we already discussed the foreshortening. The same holds, of course, true for the Octa Pro. There's more or less no foreshortening. Therefore, if you start in a position like this, if you find a good alignment, then it's usually rather easy to implant the valve. Talking about the alignment, you can help the alignment a little bit with a wire, and we saw this in the live case as well. And this is on the one side a pro, on the other side perhaps a con as well, because the delivery system does not really help a lot to align the valve. And here you have to fiddle around a little bit with the wire in order to really get a good alignment to start with the presentation. This was how it looked like during the inflation here. So balloon opened up in the upper part first. Nonetheless, the whole thing was pretty stable. And when we have a look in the result, this is promising. Valve is sitting well. Perhaps it's not 90-10, it's more 80-20 here in this case, but there is no paravalvular leak at all, and this is fine. Coming back to the pros and cons, so definitely a pro is this very short valve frame, and you could just appreciate in the live case as well. And here in this image once more, this is important for, in my eyes, for a perfect coronary access. As you can see here, there's usually no problem at all to come to the coronaries again. Then we have a low or no PVL rate, which is usually the case, very positive results here. Nonetheless, there's still a wish list. And this wish list contains, I started with 3 points. Interventional cardiologists always have wishes. So first point is, I would really be happy to see some clinical data on the current THV. So we have seen data on the predecessor, but the current THV would definitely profit from some clinical data. The sheath we saw before in the live case is perhaps, there is still room for improvement. And the same holds true for the delivery catheter. And I'm very happy to, that I heard that there is a lot of work done. And I'm looking forward to the next year's edition of EuroPCR. And hopefully most points of my wish list will be solved then. With that, thank you very much.
Very nice presentation, or maybe there is time for one question if someone in the panel wants to make it. I like it very much. Alfonso Yelassi just published the preliminary experience with Octa Pro. So now you have one paper together with the mushrooms one.
Okay.
For the
That's fine.
Any comments? Okay, then we will proceed to the closure with Joanna, please.
Sure. No, so I think there's not much that I can say to close this session, except that you saw a brilliant bicuspid case, which is obviously always a challenge for us to tackle. And you saw a beautiful CT analysis, which is actually needed to do a proper job in a bicuspid case, because it has a lot of nuances and the anatomies are very different, and you have to adjust your procedure based on this. I think the take-home is that this is a new player. Octa Pro is a new device, and the company keeps innovating a lot. So we just saw the wish list, but they have already made several iterations in a rapid-fire progression. Octa Pro is a nice new alternative for some bicuspid patients, I think. You should be comfortable with the device. I think Peter told us that he bravely started with a bicuspid case with a dilated aorta. But perhaps, we should be all more cautious. But it is, in some ways, well suited for this because it does give you optimal positioning, very little foreshortening. You have a very nice marker there. The catheter is flexible and has the flex system, where if you have the horizontal dilated aorta, which often goes together with bicuspid, it makes your life easier, and you can play with the flexibility of the catheter and the stiffness of the wire to balance that a little bit. You saw the intermediate sizes and also the ability to play with filling of the balloon or underfilling of the balloon, to really look at your chart and see how much am I comfortable with oversizing in this heavily calcified bicuspid anatomy. And I think the hemodynamic assessment and echo assessment in the cath lab to make sure that you're leaving an optimal result when you leave is actually crucial for all patients, but especially in a complex case like this.
Thank you very much, Joanna. Thank you to all the panelists. Thank you to the technical team that is crucial for the live cases. And thank you to all the attendees. With that, we close the session.